Thank you, Dr. Tom.
Thank you, George, and big thanks to Angels for inviting me to share our Czech experience with you. So I'm really happy to be here. As you have seen, I will be playing the same tune like the Julia before me, again on quality monitoring, and you will see a lot of charts, but not such a nice science as it was shown by first two speakers. So those are my disclosures. We all know that if you want to manage something, you need to monitor your quality. You know that it's a simple prerequisite to have auditors. You have to check your things. But of course, this process is pretty difficult, especially for us who are not professional managers. We are physicians, so our primary interest is in treating patients and not in looking for quality measures. But the guidelines are nicely saying this, and we know it from numerous studies that if you do this process, then you will get much more better care for your patients. The question which we have asked in our Cerebrovascular Society was how much is too much, and you know, what we would really like to know. And, but we have decided to be pretty thorough in the number of monitored things. And I will show you that we went from low-level monitoring, which brought us some standard stroke care, to a higher requirements for the centers, which brought us something in between excellent and NSA level monitoring. We know that, of course, the quality monitor would like to monitor a lot of things and then move the targets every day, but I will show you. Those are data which I present on behalf of our Stroke Society. Czech Republic, just to remind you, some of you were probably there last year, is pretty compact country. Only you see 500 to 300 kilometers roughly, with 10.5 million of population. Our stroke care is organized centrally. We don't have any big regional differences, and we were lucky that there were some structural funds from EU possible for reorganizing our system around year 2009, so it's roughly nearly 10 years. And it was supported financially by EU and our government. Then we have the system is given by the highest possible degree of by decree of Ministry of Health. So everything which we have written in it, because we were writing most of the documents as Czech Neurological Society, so that's in these decrees. So we have 45 centers which are regularly distributed throughout the country, and there are really strict requirements on what personnel, what equipment should be in each center. The list which was published as a decree has nearly 100 pages, all the documentation about what should be done and what should be there. So now to quality monitoring. We started with just annual sum values, not individual patient data, which are reported once a year to a Ministry of Health and to our societies, because it's, we are the main society leading the process as a stroke society, but we of course have close collaboration, and part of the system are interventional radiologists, neurosurgeons, emergency medical personnel. And then we collect individual patient data, which we collect throughout the whole year in all recanalized patients, and for all stroke patients twice a year for 1 month, and we analyze those data each half year. So just to show you what are the summary indicators, there is 12 of them, which were, you see, aimed at emergency medical services, stroke epidemiology and coverage of care, recanalization therapy, rehabilitation, and some interventions and surgery. So just to show you, we are usually treating something around 26,000 patients, which is probably something around 95% of all stroke cases in our country. There are some cases which go to other hospitals, but they are usually patients who are later. It's compulsory to be hospitalized in stroke center if you are 24 hours or less from onset. and or if you are a candidate of some specialized therapy. You see that with the system, and especially we have initiated a composite triage for emergency medical services. We have really felt that there is a higher number of recanalization treatments. Of course, we can't be sure if it's just a trend which is seen worldwide or if it was our reorganization of the system. But you see that last year we had nearly 5,000 thrombolyzed patients per those 10 million of population. If you look at the proportion of ischemic strokes, you see we are reaching somewhere around 25% of all admitted patients. Concerning the thrombectomies, we have out of those 45 centers, 15 are doing thrombectomies. You see that the benefit is clearly seen, and that the number is still increasing, and we are now on 6% of all admitted cases throughout the whole country. Now, a little bit more on the reporting. You see that we've started with the annual monitoring, and what we then did was to report the concrete data of each center to every center each month. That we began with this project in 2016 with a generous support from Angels, helping us with analyzing the data and making the reports. And we are sending such reports to each center every month. I will show you. We concentrated with those reports first on how the treatment should be fast and how many patients are covered. So we do monitor and send to center. You see its median onset to hospital time to compare emergency services and availability. We then send now also door to imaging and door to needle. For the cases where there is a secondary transport from primary to comprehensive center for thrombectomy, we measure their median monthly time of transport and also door to groin time for each respective endovascular center. You see those reports look like this. When we've started in June 2016, only 1/3 of the centers were filling the data, so we were able to tell them how they are. But you see then in 3 months, we have reached nearly 100% coverage, and now every center is reporting continuously the data for recanalized patients. So we then, with a 3-month slide, can report them how they were doing 3 months ago, because it's more practical. You see that the reports are colored. The green color is when your median time of recanalization is below 30 for all patients in the center. So you see with this respective method, we've reached a really lot faster results. We were not happy with median below 30, so we've introduced just last month coloring also with orange. So now you can be green. It means good in between or among your peers, only if your median is below 20. So you see that still 1/3 of centers is having median time door to needle below 20. You see now those are average numbers for whole Czech Republic, and you see that in each quarter the time really went down. This is counted from individual patient data, so it's pretty, I would say, illustrative of this case. And you see that we've just with this project for whole country, we've put it down 10 minutes, and I must show that it's 10 minutes from times 37, which is always much harder than when we are pushing in between 60 to 40, where it's really easy, because you can really save time more easily. You see now this is the mean, and you see that the curve is, it began with the annual reports going down, but you see the data only once a year, so it's not so effective, we thought. And you see that with monthly reports, now the curve goes, at least, as you can see, much faster down. When we compare ourselves to the countries, for example, in rescue register, which was done just this March, so we really had this median of 20 also reported in those patients. What we also do monitor is, of course, and I really like the example of Austria, looking for the gaps, looking for some patient groups or regions where the care is not optimal. So we have started with monitoring as the Austrians different regions, if they are in the same level of care. And now we are planning to move again to the groups which are endangered by some maybe different and lower standards as the elderly and so on. You see that this is the coverage of population in different regions of Czech Republic and recanalization treatment. With our quality monitoring program, we haven't stopped at the acute care and the times and coverage, but we also would like to move it more to the secondary prevention and other treatments than just recanalization. So we are sending those reports now twice a year. That was a surprise for us because we did it initially once a year, but then we had a meeting of all centers and we've asked them, do you want to do the quality monitoring of all patients once or twice a year? And 85% voted that they want to do it twice a year, which means they have to put many more patients into the registry with all data. So this is example how they will get, and again I will show it's not marked by some abstract numbers, but every center sees each other and they know how their neighbors are doing, which I think is really important moment. So what we look for in rescue, we look for other acute treatments, not just recanalization. So of course, dysphagia screening, hemicraniectomies, and acute physiotherapy, how it's applied. We also look for intracerebral hemorrhages, if there are procedures done, and what's the outcome of the patients. And we look a lot on secondary prevention data, how the AF is screened, how are the patients of course, sent home on anticoagulation or antiplatelet, smoking cessation programs, and also if there is a planned follow-up and we want a concrete date from all centers in a stroke specialized outpatients department. So you see, again, a comparison of year 2016 to 17. For example, dysphagia screening, which wasn't so good in some centers and they didn't do it at all. You see that after we've started the quality monitoring program, we have seen a large impact of this. And it was also seen in the Angels Award, where in the year 2017 our centers were not getting any awards because usually of low percentage of dysphagia screening. Now it changed and nearly 20 centers got the award. This is the same for anticoagulation. So to conclude, I think, of course, you need to set some realistic and well-defined targets, but as we have seen, we usually set some target and 1 year later we are surprised that we have set it too low. So you better plan for just half a year, not 5 years. Like I remember EU wanted like 5% thrombolized by 2015, was it? Yeah. And everyone will laugh at this target now. Of course, you need to balance between wanting to be better and the centers putting truthful data. We have a chance to send an audit to the center, and we did it a couple times. If we think, like executive committee, looking at the data, that there are some discrepancies. And of course, I think that you need to give awards, but also to punish a little bit those who are the worst. So we have sent already some letters, official letters, and we even used a Ministry of Health to help us with those letters to the centers. And it really helps if you send them an ugly letter telling you if you are really not getting better, then your center is endangered by closing. So to conclude, I think a centrally organized system is, of course, much better, equipped for quality monitoring. And I think if you do it, you have a chance to make your treatment much better. Thank you.